Let's start with Dr. Timothy McLure from the Weill Cornell Medicine, who's talking about contemporary role of novel imaging tools for preoperative and intraoperative planning in the MRI world.
Good afternoon, everyone. I could literally set up a meeting just talking about this topic itself. So I'm going to discuss where I see kind of some novel imaging where it's impacting me, and I think it may have real impact on us as clinicians. And then I'm at the very end just going to highlight some of the sessions that occur at this meeting that are going to highlight some of the new novel imaging aspects that is really going to help change patient care management, I think. These are my disclosures. The only relevant one is that I have a prostate spore career enhancement program award, as well as some NIH funding looking at PSMA PET in the active surveillance patient population, and I will be talking about PSMA PET today. We all know that MRI really has revolutionized prostate cancer diagnosis and management. There's numerous randomized controlled trials that have demonstrated that prostate MRI improves the detection of prostate cancer, particularly clinically significant prostate cancer. And it's really because of prostate MRI that I think the field of focal therapy kind of really took off too, because the first time we could really see prostate cancer for the first time and help guide therapy and guide biopsy treatment. The Precision trial highlights this, and it demonstrates that MRI really does help identify clinically significant cancer. But it also shows some of the limitations with imaging. So this is the PIRADS rating scale, and as you can see, there's quite a bit of variability with the ability of MRI to detect prostate cancer that matters. A PIRADS 5 lesion has about an 80% chance of finding clinically significant disease, whereas a PIRADS 3 lesion only has about a 10% chance of finding clinically significant disease. What does that mean? That means almost 2/3 of patients with a PIRADS 3 lesion get a biopsy that's not necessary, and about 20% of patients get a diagnosis of prostate cancer that we don't want to know about, and they don't want to know about, and their healthcare insurance doesn't want to know about, because that results in anxiety, repeat biopsy, repeat imaging, and repeat PSA checks, which is stresses. MRI also misses clinically significant cancer when you look at whole mount pathology. So this is from Rob Ryder's group, where he looked at 600 patients who underwent a preoperative MRI and then subsequent surgery. And what you see here is the dark bars are detecting cancer, the light bars are not detecting cancer, and this was before the pathology grade group change. But you can see that Gleason 3+4 and above, 40 to 20% of prostate cancers were missed. About 20% of grade group 4 were missed. And if you look at that whole concept of the index lesion and being able to see it, about 1/3 of patients with an index lesion would not have been seen with MRI. So what tools exist to help augment the MRI? Now there's lots of sequences that can be done, but oftentimes the sequences that are done require an expertise that isn't necessarily applicable to the entire population. And PSMA PET may be one tool that can be used more routinely and generalizably to the entire community. This was a fantastic study from Australia called the Primary Study, and they looked at the ability of PSMA PET to improve the diagnosis of clinically significant prostate cancer. What this was a phase 2 study, prospective at 3 academic centers. It included 296 men, and they basically were men who had never been biopsied, never had an MRI before, who presented with a PSA less than 20 or an abnormal prostate exam. They underwent an MRI, a PSMA PET, and then they underwent a biopsy. A PSMA PET was considered positive if the SUV max was above 4. They had to use that arbitrary value because the PSMA PET was just of the pelvis, so they didn't have the whole liver pool or blood pool that you can use with a whole body PSMA PET. And they viewed a positive scan as a PIRADS 4 or 5, which we'd expect, and then a PIRADS 2 or 3, that radiology hedge that most of us don't enjoy. They'd view that as a positive if the PSMA PET was positive, and if the PSMA PET was negative, they viewed as negative. And what they found was interesting. When you added the PSMA PET to that algorithm, you saw improved sensitivity as well as improved negative predictive value. So MRI alone had a sensitivity of about 83%. PSMA PET by itself had 90%, whereas both combined had 97%. Whereas the negative predictive value was only 72% with an MRI, increased to 80% with just a PSMA PET. And when you combine those treatments, it went up to 91%. So showing the additive value of PSMA PET in patients with elevated PSA who'd never had a prior workup. They're now expanding this now. This is an ongoing trial. It's called Primary 2, and it's a randomized controlled trial looking at patients with an abnormal MRI that's either PI-RADS 3, so that equivocal, or a PI-RADS 2 with a high PSA and high PSA density. And they're randomizing those patients to either standard of care biopsy or PSMA PET. And if the PSMA PET is positive, then they'll undergo biopsy. If it's negative, then they won't. And I think this will be a critical trial that we want to pay attention to, because I really do think that this will be groundbreaking with regards to helping better diagnose patients with prostate cancer. These trials, well, particularly the primary trial, really inspired myself and my co-PI, Himanshu Nagar, to look at the use of PSMA PET in an active surveillance population. So we have a trial started calling ESCAPE, which is where we're following patients with either favorable intermediate risk prostate cancer or low risk prostate cancer, and we're using PSMA PET in that population to see if that helps us better identify patients who progress to definitive treatment. Now, it's a focal therapy meeting, so we have to talk about focal therapy to a certain extent. Stricher's group also looked at the use of PSMA PET in seeing if it helps improve patients for selection of focal therapy, because we know there's limitations to it, particularly with recurrence. What they found is when you use PSMA PET in addition to prostate MRI and prostate biopsy, you saw improved sensitivity as well as improved negative predictive value. With just the MRI alone, a 59% sensitivity, whereas both biopsy, MRI, and PET, a sensitivity of 87%. A negative predictive value by itself, 70% with MRI, whereas 86% with all three components. So there's a potential role for PSMA PET in the patient selection for our focal therapy patients. Now for the meeting and what to keep an eye out for. So on Friday morning, they'll be talking about AI and the emerging modalities that might help us better identify patients who need treatment. Similarly, in the morning on Saturday, although it's early, I think it's worth getting up for. They're going to be talking about the basics of AI, going over how AI may help our radiologists make better diagnosis, as well as AI in pathology. AI really will revolutionize how we look at these somewhat subjective images and make it more objective to make better diagnoses. Mid-morning on Saturday, there's going to be review of advances in prostate imaging, including updated reporting techniques for post-ablation treatments, PSMA PET imaging again, as well as the use of ultrasound imaging in prostate cancer management for focal therapy. And then one of my colleagues, Liz O'Dyer, who's fantastic, she's going to close the meeting talking about novel imaging tools for surveillance after focal therapy. Thank you very much.